Talk about ankylosing spondylitis. This is going to be a broad overview about the topic rather than significant or joint or spine issues which will be dealt in the specific topics. We are not going to talk about the details about the surgery, but the disease as such, right? Ankylosing spondylitis is basically a chronic. It's a chronic seronegative, right? Very important. Why are these diseases called seronegative? Because rheumatoid factor is negative. It's a chronic seronegative autoimmune spondyloarthropathy. It mainly involves the spine and the large joints, unlike the rheumatoid arthritis, which involves the smaller joints of the body first. Ankylosing spondylitis involves the larger joints and the spine, and it involves joints like the hip and shoulder first before it involves the other smaller joints. Diagnosis is usually made with the presence of HLA-B27 and associated other conditions. Treatment is usually basically observation and NSAIDs initially and followed by surgical treatment in later conditions, right? So let's go to the introduction. That was in brief about ankylosing spondylitis. In epidemiology, it is a much higher incidence rate in males as compared to females. The male is to female ratio is 4:1. This is in complete contrast to the rheumatoid arthritis, where the male is to female ratio is reverse. It's probably 1:3 or 4. So more number of females are affected than males. So this is the incidence rate. It usually presents in the third to the fourth decade of life, in the third and fourth decades of life. And most of these patients, more than 90% of these patients will have HLA-B27 positive. More than 90% of patients will have HLA-B27 positive. They're very important. What is the pathoanatomy? The exact pathology is unknown. The exact mechanism is unknown. There is some relation to, as we know, HLA-B27. More than 90% of patients are HLA-B27 positive. And maybe it is theorized that the HLA-B27 aggregates with peptides in the joint and causes a degenerative pathology or problem. So unlike the rheumatoid arthritis, the exact pathophysiology and the pathoanatomy is unknown. What we know for sure is enthesitis occurs. What is enthesis? Enthesis is where a ligament, tendon or bone, ligament, very important to understand because this will be the basics of your understanding about ankylosing spondylitis. Ligament, tendon or muscle. When it attaches to the bone, this junction is called the enthesis, and this is the area which is affected in cases of ankylosing spondylitis, and this is called as enthesitis. It is called as enthesitis. And this leads to further bony erosion surrounding soft tissue ossification, and eventually bony ossification and ankylosis, bone formation, and it causes ankylosis. So this preferentially, as we discussed, targets initially the sacroiliac joints. It can target the other areas of the spine and also the other large bones of the body, which include the hips and the shoulder. So usually the larger bones are the larger joints are involved in this condition, and usually they also the disc space is also involved. Disc space ossification occurs in ankylosing spondylitis. So let us now come to the diagnostic criteria. What are the diagnostic criteria? The most important thing we have learned is that HLA-B27 should be positive. Sacroiliac joint is associated first, and it should be present most of the times for a diagnosis of ankylosing spondylitis. We may have plus or minus uveitis. The uvea is also involved or inflamed in the eye, and so uveitis, sacroiliac joint involvement, and HLA-B27 positive. These are the form the basis of the diagnostic criteria for ankylosing spondylitis. There are a lot of systemic problems that are involved in ankylosing spondylitis. These include uveitis, we have discussed already. There is pericarditis, pulmonary fibrosis, renal amyloidosis, aortic regurgitation and aortic issues, Klebsiella pneumoniae. So they have ankylosing spondylitis patients have a peculiar abnormality of susceptibility to Klebsiella pneumoniae type of pneumonia, and this must be kept in mind when treating these patients. Now, what are the clinical signs and symptoms? Usually, most of these patients present with early lumbosacral pain and stiffness. That is, sacroiliac joint is the first one to be involved in the most commonly involved joint. And this is mostly worse in the morning, and this is an insidious onset usually seen in the third and the fourth decade, mostly in male patients. They also have neck and upper thoracic pain. The other parts of the spine, as compared to the sacroiliac joint, happen later in the disease progression, And if you have an acute neck pain, always look for fractures. You should always look for any acute neck pain in an ankylosing spondylitis patient. You should look for fractures. You also have sciatic nerve pain. Patient has a loss of gaze because of this increase in the angle, chin brow vertebral angle. This angle increases, and therefore the patient will look down, will have kyphosis in the thoracic and cervical region, and the patient's gait and the posture changes as well. Posture changes as well. And we all know there is a decrease in the chest expansion. So a decrease in the chest expansion of less than 2 centimeters is very, very specific and sensitive for ankylosing spondylitis. We all know about the Schober test. The Schober test, when there is less than 5 centimeter change in the spinal movement when the patient bends forward, is called the Schober's test. We will discuss this in clinical examination in more detail. This is also very important for the diagnosis of ankylosing spondylitis. So the chin brow to vertebral angle is called the CBVA angle, chin brow to vertebral angle. So the chin brow to vertebral angle is important, and post-surgical correction of this angle is important for the gait, gaze, vision, prevention of future fractures, improvement in the posture. All these are important, and this is seen by observing the chin brow vertebral angle, CBVA, chin brow vertebral angle. And all of us know there is a provocative test for sacroiliac joint, which is the most specific and sensitive test that is important, is called the Faber test. The Faber test, as the name acronyms suggest, flexion, abduction and external rotation of the hip and compression can cause or elicit pain, and this indicates sacroiliitis or sacroiliac joint problems. Next, coming to diagnosis via various modalities including radiographs. So in radiographs, basically we will see we should get the spine full length standing, and AP and lateral view of the spine must be done. Here we will see squaring of the vertebra. We see the squaring of the vertebra. We have marginal syndesmophytes, bamboo spine. These are all features of these on the X-ray of the spine. You have a bamboo spine, squaring of the vertebra, marginal osteophytes, that is where the ligaments attach to the bone, that is where the bony ossification starts and progressively becomes completely bridging bone, and this is called as ankylosis. You should also measure the chin brow to vertebral angle as described on the lateral X-ray must be done. In the lower extremity and the pelvis, you should do what is called as a Ferguson tilt view. Ferguson pelvic tilt view. This gives the best image of the sacroiliac spine, and this is an important X-ray to take to look for the initial changes in the sacroiliac joint and for the initial diagnosis of ankylosing spondylitis. Right, the earliest sign that you see in sacroiliac joint in the Ferguson pelvic tilt view is the erosion of the iliac side of the sacroiliac joint. So you have the erosion of the iliac side of the sacroiliac joint. So Ferguson pelvic tilt view is usually for the sacroiliac joint, to observe the sacroiliac joint. Now coming to CT, when will you do CT? CT is very important for fractures. So whenever the patient has pain after mild trauma, because now the spine is fused into one single piece, therefore there is a very high chance of fracture of the spine, and even trivial trauma can cause fracture. So one must be very careful and look for the fractures, and whenever you have a low index of suspicion for fracture, and CT scan should be done for the fracture. MRI should be done in early stages, which may indicate inflammation. So when the diagnosis is not clear, we can do MRI, and to also rule out epidural hemorrhage. You can do epidural hemorrhage to rule out epidural hemorrhage. So basically, the function of CT is to rule out fractures. MRI is to rule out inflammation and epidural hemorrhage. Bone scan is of not much use and is not regularly done in ankylosing spondylitis patients. Now coming to the differential diagnosis, we have to majorly differentiate between what is called as a DISH. So DISH and ankylosing spondylitis have to be differentiated. So let us differentiate between these two conditions, DISH and ankylosing spondylitis. What is DISH? DISH is a diffuse idiopathic skeletal hyperostosis. Diffuse idiopathic skeletal hyperostosis, right? So let us differentiate between these two diseases. So in syndesmophytes, right, where do you see the syndesmophytes in DISH? You see it is not marginal, non-marginal, whereas the syndesmophytes in ankylosing spondylitis are marginal because it is an enthesitis, right? DISH is not an enthesitis, so only the ligaments and tendons where it attaches, it will form osteophytes or syndesmophytes. So basically it is a marginal disease in ankylosing spondylitis. The second difference between these two in X-rays, in radiographs, you have a flowing wax type of pattern in DISH, whereas you have a bamboo spine squaring of the vertebra, and you have shiny corners of the attachment of the annulus fibrosus, which is also called as Romanus lesions, Romanus lesions. The third difference between these two conditions, where you see the disc space is preserved, and as we have discussed earlier, there is ossification of the disc space and there is a reduction in the disc space in ankylosing spondylitis. Now coming to the fourth difference, osteopenia, right? We see no osteopenia. Basically, the name itself says it's a diffuse idiopathic skeletal hyperostosis. So there is increase in the bone density rather, whereas in ankylosing spondylitis there is a decrease in bone density, and therefore, and because of the ankylosis, there is a higher chance of fracture even with trivial trauma. Then we all know the different very important difference is the HLA. There is no HLA association, whereas more than 90% of cases have HLA-B27 association in ankylosing spondylitis. The age group in which it occurs, and DISH occurs in much older patients, whereas ankylosing spondylitis is first seen in third and fourth decade of age group. And another difference is sacroiliac joint involvement. There is minimal or no sacroiliac joint involvement. There is always a sacroiliac joint involvement in ankylosing spondylitis. Then coming to diabetes, the DISH is always diabetic, the diffuse idiopathic skeletal hyperostosis is always or most of the time associated with diabetes, whereas there is no association with diabetes for ankylosing spondylitis. So these are some of the differences between DISH and ankylosing spondylitis. To recap, DISH is non-marginal syndesmophytes. In ankylosing spondylitis is marginal syndesmophytes. Radiographs are flowing wax in DISH. It is bamboo spine, squaring of vertebra, and Romanus lesions in the disc space in ankylosing spondylitis. The disc space is preserved in DISH. It is reduced in ankylosing spondylitis. Osteopenia is increased in DISH and it is decreased in ankylosing spondylitis. Bone density is increased in DISH, whereas it is decreased in ankylosing spondylitis. No HLA association in DISH, whereas HLA-B27 strongly associated in ankylosing spondylitis. And this disease is more common in third and fourth decade, as DISH is common in older patients. So these are some of the differences between DISH and ankylosing spondylitis. The first line of treatment is non-operative treatment. You start off with NSAIDs, COX-2 inhibitors, and this is the main treatment. If this fails, the second line of management is TNF alpha blocking agents. What are the TNF alpha blocking agents we know of? It includes infliximab, etanercept, and adalimumab. These are the three TNF alpha inhibitors and blocking agents, and the second line of management. Now coming to a little brief about some of the injuries that we see and some of the pathology that we see in ankylosing spondylitis. We see spinal trauma very common. It's very important to have a low index of suspicion for these injuries because these occur with low or trivial trauma. CT scan is a must to rule out fractures, and the fractures most commonly occur in the mid-cervical area, cervicothoracic junction, and rarely in the lumbosacral area as well. These are usually extension type fractures which involve all three columns. The mortality rate is very high and neurological complications are very high, and therefore there should be a low threshold to fix these fractures. So you have to fix these fractures either anterior or posterior, whichever is appropriate. So you have to fix these fractures. And CT scan, as I said, is the most important investigation that is to be done for identifying these deformities. Spinal deformity is very common. It's usually a kyphotic deformity. There is a very high chin-brow vertebral angle, and the patient's gait, posture, and visual problems occur, and therefore this has to be corrected. And this the various techniques in doing this includes closing wedge pedicle subtraction osteotomy, which we will discuss in spine, right? Closing wedge. But you have to just write this in your exam when they ask about ankylosing spondylitis. Pedicle subtracting osteotomy, right? Then this is the most common type of osteotomy that is used. You also have other types of osteotomy to correct this these kind of deformities, including opening osteotomy, single level opening wedge osteotomy, multi-level opening osteotomy, and these are other techniques that are available to correct these deformities. Hip joint is the most common large joint involved in ankylosing spondylitis. The most common treatment once there is involvement of the hip is the total hip replacement, irrespective of the age. We also do this very commonly in younger age group as well. And there are multiple issues associated with this. The important things that you would understand about replacement and hip replacement in ankylosing spondylitis is that patients have a more vertical and anteverted acetabulum, and hence this may lead to higher dislocation rate. There is a higher dislocation rate. So there is much because you're in bony ankylosis, you have to take down the bone. There is much higher risk of bleeding, and so we have to be very careful when taking care of these patients. So with that, this is in brief about ankylosing spondylitis. It does not encompass all the diseases or the problems involving the joints and spine, which we will dealt in their respective topics, but this gives a brief overview of ankylosing spondylitis so that you can answer this in your exam. Thank you very much.